When a medical mistake costs a patient their life, the demand for justice is usually swift and severe. Society expects someone to be held accountable. That demand is rooted in real tragedy. 6-year-old Jack Adcock died of cardiac arrest following a series of clinical errors. 75-year-old Charlene Murphy was mistakenly injected with a lethal paralytic agent. Behind the legal cases are families navigating a level of grief that is difficult to overstate. The people responsible for those errors weren't negligent actors, but highly trained professionals. Dr. Hadiza Bawa-Garba, a pediatric registrar, and Nurse RaDonda Vaught. Both arrived at work intending to save lives, both left having ended one. The legal system treated them as criminals. Both the doctor and the nurse were prosecuted, criminally convicted, and stripped of their professional licenses. On paper, this is how justice is supposed to work. But safety experts watch these convictions with growing alarm. By focusing the entire weight of the law on individual punishment, the legal system created a new kind of risk, one that prioritizes retribution over understanding the conditions that allowed these deaths to happen. To see why those conditions matter, we have to use the lens of local rationality. This is the idea that a person's actions almost always make sense in the moment, given the tools they have, the pressures they are under, and the information they can actually see. On the shift when Jack Adcock died, Dr. Bawa-Garba was left with sole responsibility for an entire unit due to a scheduling error. The senior consultant who should have been supervising her wasn't even on site. This timeline illustrates the information gap she was working in. Because of a massive IT failure, critical blood test results were delayed for over 5 hours. She was forced to make life-or-death decisions while effectively blind to the patient's actual condition. Nursing communication was also fragmented. Jack's mother, unaware that his heart medication had been discontinued, administered a dose herself, a standard practice for parents in the unit, which triggered the final cardiac arrest. When a trainee doctor is managing a ward alone, without senior cover, and using a malfunctioning IT system, errors are no longer aberrations. They are the predictable outcomes of a system set up to fail. Nurse RaDonda Vaught faced a different set of systemic traps. To ease a patient's anxiety before a scan, she went to a notoriously unreliable automated dispensing cabinet to pull a common sedative. When the cabinet software didn't recognize the drug's brand name, Vaught triggered an override, a workaround that staff were routinely taught to use just to do their jobs. In the confusing list of generic labels, she accidentally selected a lethal paralytic instead of a sedative. The hospital had previously removed critical layers of defense. There was no requirement for a second nurse verification for overrides, and the radiology department lacked the barcode scanners needed for a final bedside check. Following the error, the medical center fired Vaught, but initially reported the death as natural causes. The institution avoided the authorities for months, concealing the very systemic gaps that had made Vaught's mistake possible. Firing the nurse satisfies the need for blame, but it leaves the hazards in the room. The cabinet, the naming conventions, and the lack of scanners remain, waiting for the next person to walk into the same trap. Healthcare systems only get safer if workers feel secure enough to report their near misses and errors. Safety depends entirely on data that only the staff can provide. In both cases, the practitioners provided that data. Vaught was immediately honest about her mistake. Dr. Bawa-Garba wrote detailed reflective notes, a standard part of medical training designed to help doctors learn from their own performance. But in a move that shocked the profession, prosecutors legally seized those notes and weaponized them as evidence. They took a document designed for education and read it to the jury as a criminal confession. There is an intellectual dishonesty in this. Reflective notes are hindsight documents, written in calm moments after the outcome is known. Using them to judge a doctor's chaotic, split-second decisions on an overstretched ward is a total misuse of the material. When the act of learning is turned into a tool for prosecution, the choice for a doctor is simple: be honest and risk prison, or stay silent and let the system stay broken. This choice is driven by the observation effect. Most clinicians will never be prosecuted, but they don't need to be. Watching a colleague get criminalized for an admission of error shifts how the entire profession calculates the danger of speaking up. This graphic shows the fallout. After the Bawa-Garba case, surveys found that over 80% of junior doctors changed how they wrote their reflections. They began self-censoring their own learning logs out of a rational fear of the law. The resulting outrage fueled grassroots campaigns across the globe. These professionals weren't arguing for an exemption from responsibility. They were warning that a culture of silence is the single greatest threat to patient safety. This is why experts advocate for a just culture. This framework distinguishes between human error in a bad system and actual recklessness. It recognizes that you cannot punish a system into being safer. Right now, somewhere, a nurse is deciding whether to file an incident report, and a doctor is wondering what to write in their log. They are weighing the needs of future patients against the risk of their own professional destruction. Silence is the deadliest outcome in any hospital. If we want people to speak up, we have to make it safe to tell the truth. That requires a legal system that protects the worker, so that the worker can protect the patient.